So once again, this is Dr. Anita Sachin, your MC for the session. If you wish to claim your certificate for the same, kindly visit our website, which is www.onlinedentistry.in/9 p.m. and register for the same. Online dentistry has been the pioneers in providing dental education via both online and offline platforms. Established in the year 2008, it has been over 14 years that online dentistry have been conducting sessions for clinical practitioners across the globe. We have an enormous amount of more than 30,000 followers in our platform. Let me proudly introduce the CEO of online dentistry, Dr. Binuti Abraham. He's one of the finest practitioners in town, serves an orthodontist by profession, a passionate photographer, and he owns his private practice at Kerala Dental Clinic, Aluva. And currently, he's interested in educating thousands of clinical practitioners through online and both offline sessions. Moving on to the academic head of online dentistry, Professor Dr. Joby Peter. Sir is currently the HOD of Department of Pediatric Dentistry at Anu Dental College and Hospital. He preaches the philosophy to catch them young and watch them grow. Over the years, we have grown dynamically, launching 10 centers in different parts of India. On popular demand, the latest addition to our courses, the one-year comprehensive and advanced master training program on interceptive and myofunctional orthodontics have been successfully initiated with 2 batches. So this is basically a multidisciplinary approach with intense training and hands-on session. Our program is basically a fellowship program on interceptive and myofunctional orthodontics, which is accredited by the Manipal University College, Malaysia, which is a sister concern of Mahi University. Herein, 2 of the modules will be happening in Malaysia, along with the graduation ceremony and a certificate distribution as well. On popular demand, we are relaunching the most awaited 3-day CDs at Bangalore on 21st, 22nd, and 23rd of June 2024. So grab your seats before it gets booked. You can always feel free to reach to us on our WhatsApp number or visit our website, which is www.onlinedentistry.in, or else you can mail us on onlinedentistry.in@gmail.com. Online dentistry have been conducting sessions all over India for past 14 years. So during the lockdown, we started conducting online sessions to benefit the practitioners, which have been received with great appreciation from dental fraternity. In the year 2023, we are relaunching the same under the heading Online Dentistry at 9 p.m. And so here we have with a Q&A session. And before moving on, let me introduce the speaker for the day, Dr. Ritul Agarwal. Dr. Ritul Agarwal is a distinguished prosthodontist and implantologist over 11 years of experience. He completed his master's from the reputed Savida University and secured his bachelor's from Manipal University. He was awarded the prestigious membership in prosthodontics from the Royal College of Surgeons, Edinburgh. Sir have worked in Dubai Health Authority and medicine for over 10 years, and he was awarded the fellowship in dental surgery from the Royal College of Surgeons, Edinburgh. He has also been awarded the prestigious Fellowship of International Congress of Oral Implantologists and membership in prosthodontics from the Royal College of Physicians and Surgeons, Glasgow. He is also a well-renowned international speaker and key opinion leader for Dentsply UAE. On behalf of Online Dentistry, I proudly welcome you to the session. Welcome, sir.
Thank you so much. Thank you. Thank you.
Yeah, so without further ado, let's move on to can we move on to the Q&A session, sir?
Yes, for sure.
So, sir, the first question for the day is, sir, how do you select patients for smile designing in dentistry?
So coming on to patient selection, that's a very important question when it comes to cases when we look at patients for smile designing. The number 1 criteria is patient motivation. So if my patient is not asking for it, generally I would not talk about it much, because what I understand is once we try to sell a treatment plan to a patient, it generally backfires sometimes. So, patient is wanting, of course, I mean, I have a discussion with the patient, but it also depends on the patient's interaction with my front desk, how they talk to my reception, how they talk to my nurses. I mean, are they willing to, pay for the basic consultation, or they are asking for free stuff already at the front desk, right? So when we treat patients who, I mean, I know that these treatments are expensive treatment at the end of the day. So if my patient is not willing for a basic motivation, he's not motivated for basic oral hygiene, you are trying to tell the patient to maintain oral hygiene and they are not. then I think it's better that, I kind of stay away from those kind of patients. Yeah.
Right. Okay, sir. So moving on to next question, sir. So how do you determine the ideal proportions and symmetry for a patient's smile?
All right. So now when we kind of look at proportions for smile, there are multiple things that we have to look at when we design a smile. First thing, of course, is something called as the incisor length. Now that's the most important criteria when we come to do any aesthetic case is where and how my central incisor should look like. All right. So whoever has attended my lectures before, they know the concept of visagism. All right, wherein I decide the shape of the tooth based on the personality of the patient. So a patient who would want to project themselves as a leader or somebody who wants to project as a strong personality, I would go with a rectangular tooth shape. Whereas more, female patients or somebody who would want their personality to come across as a more feminine personality, I would go with more oval teeth. So that's the basic criteria of the tooth shape. But the incisor length, if you want, you can know this formula of 42.2 rule. All right. So a 4 millimeter incisor display for women at rest. Generally for males, it's around 2 to 3 millimeters. The first two is the gingival display. So when the patient is smiling fully, you would want ideally to see around 2 millimeters of gingiva. But then again, it's not possible in all the cases based on this lip line. There is a little bit of a difference. And lastly, there should ideally be a 2 millimeter distance between the lower lip and your incisal edge when the patient is smiling. So that's the 42.2 rule. All right. So 4 millimeter incisal display, 2 millimeter gingival display, and 2 millimeter distance from the lower lip to the incisal edge. So when the patient walks in and they ask about smile designing, and I have to show them how they look, this is the criteria I decide to do my direct mock-up, that this is how my central incisor should look like. And then based on my central incisor, I design the remaining smile.
Remaining smile. So that's a secret formula.
Yeah.
Noted, sir. So, and sir, could you just explain the process of smile analysis and how it informs us about the treatment plan?
So let's take it from where I ended the last question. So smile analysis, of course, is in a whole process. It is not just the teeth that we are working on. So it's the whole patient that we are eventually working on. So of course, once we do the direct mock-up, I assume that the smile that I have done, I'll show you a couple of cases sometime during the presentation today, all of you, so you get the whole idea of the protocol, how things go, and how I do it. But in general, I mean, what I do is once I do my central incisors, I know that they are in good proportion and good shape. I generally follow the red formula, which is the recurrent aesthetic dental proportion. So basically, if my central incisor is around 10 millimeters wide, my lateral incisor is going to be around 7 millimeters wide, rather than following the golden proportion, which says 0.618, which is around 6 millimeters wide. So it's you might be thinking that 1 millimeter won't make that big a difference, but in general, when you add up everything, it's a lot of difference that it makes. And in human eyes, a red proportion works better than the golden proportion. So once I'm sure with my central incisor design, I go on to my lateral, the canine, keeping in mind my buccal corridor as well, which is also an important aspect when we are designing smiles because you want to see some part of the dark shadows around the mouth. So some people tend to widen the smile too much. It kind of starts looking very fake, especially when you're doing complete dentures and stuff. And some people would really narrow it down, and some people just do 6 teeth. So I generally never do 6 teeth veneers. It's either 1, 2, I mean, if I'm really correcting only the front teeth, or 10. It comes across as very aggressive. But then if you only work till 6 and leave the premolars, then you have a sudden step between the canine and the premolars, and it really looks unesthetic.
Very messy.
Yeah, so if you really want to, like, if you're working on aesthetics for a patient, then generally premolars are considered teeth that fall in the aesthetic zone and are generally should be involved in veneers. Let me make it very clear here that I am very choosy about my patients. So I don't do veneers on very young patients. If a patient is around 18-year-old, 20-year-old, I know for a fact that whatever systematic reviews or you read the research of it, lifespan of a veneer is around 10 to 15 years. I mean, even if you are the best dentist in the world, it's going to last. I'm talking about both the functional and the aesthetic life. It might just stick to the tooth for 40 years, but will it look good? No. So generally 10 to 15 years is the lifespan of a veneer. I would not cut teeth for a very young patient or somebody who just wants whiter teeth. So I think there is one question regarding the planning of the case, but in general, that's the thing that I like to follow.
Yeah, got it, sir. So, and also, this one is a tricky one, sir, actually. How do you convince patients for smile designing? You have already told us that
Yeah.
you do
So
pretty
again,
much.
convincing is one, the patient has to be a little convinced themselves
Uh-huh.
initially when they come and see me. So it has to probably be a consult for aesthetics. That if that is that, then I would, try to convince more. Second thing is if I really feel that the patient could benefit from it, but the patient is not well aware about the fact. So patient is suppose 45-year-old,
Mhm.
teeth have been like there has been tooth surface loss. I can see there are issues in the patient's teeth, and I know that if I do a smile design, patient would feel happy about it, and maybe they don't know it about it, but they would consider it. So I mean, being in practice for 10 to 12 years, you would know when you start talking to a patient to understand the basic, psychology of the patient. So then generally I do something called as direct mock-up. So I take some composite, I roll it in a ball, we apply it onto the tooth. And that technique should take not more than 5 minutes. So basically you will have to keep the restorative dentist, your composite dentist out of the head. You have to work basically like just a basic, like a dentist. Take some composite, roll it in a ball. I apply it on the dental incisor, making sure the principles that we spoke about, the 42.2 rule and the red proportion and all. And I do a direct mock-up for the patient. So which is from premolar to premolar. And I generally use like a A1 or a bleach white shade when I'm doing the direct mock-up. So the patient feels the difference. I don't want to use a A3 or A3.5 to the direct mock-up, even though it might still look good, but why should I show the patient the dark teeth? So I generally prefer doing a A1 or a B1 or a bleach white shade composite. I'll do a quick direct mock-up. Once I do the direct mock-up, the patient sees themselves. I never show the patient the mirror. It's always about taking photos. So I take photos on my phone for this. Quickly, I can make a collage of before and after, and then I can show it to the patient. Let me just share the screen here quickly so you get an idea what I am talking about. Let me go there. Where is that slide? I have a slide somewhere. Let me find. Yeah, here it is. All right. So this is direct mock-up. I mean, if you look at these pictures, it was just done in 2 minutes. All right. So you just apply some composite on the patient's tooth. We take pictures on the phone. I make a collage like this and show it to the patient. And then it is just to give that wow factor. I generally don't use Photoshop or a digital smile designing software. There's a question of that later, why I don't use it. But generally, I like to do something like this. Show it to the patient. Tell them that this is how you can look. Okay, especially if a patient who has lost vertical dimension or something and the face is overclosed, I would put some composite on the molars, make like a blob, put it on it, and just ask the patient to bite a little bit and cure it. So then the bite is open, so the face changes, and then I do the direct mock-up, and it kind of helps me to convince the patient. I mean, and then of course, now that he has got this question, let me come on to this. So what does treating an aesthetic case involve? Okay, so there are a lot of things that we need to understand when we are doing a like aesthetic case, because at the end of the day, we are touching teeth. Okay, I don't believe in non-prep veneers. So most of my cases that I do require some form of preparation, and most of the cases would be irreversible, right? So we all agree smile designing, we all know techniques, we all know alternatives. What we don't talk or what we don't understand is number one, consent. So whenever we are talking to the patient, I would always talk more about the bads than the goods. I know this doesn't sound like a very good selling strategy when you talk more about the bads, but it's important for your patient to know what they are entering into. If you hide basic facts of sensitivity, tooth preparation, what can happen if you prepare the tooth, what are the alternatives, whether are you giving them the alternative of whitening or are you giving them the alternative of orthodontic treatment, those are very important when it comes to consent. Ethics is very important. So that is something that we should all abide by. That's why I'm saying for very young, you would not find a patient of mine who is very young. They'll all be somewhere in their 30, 35s, 40s. Only one or two cases I have done who are like 22, which had bad teeth to start with. Okay, but generally, a lot of people I've seen for minimal grounding, they would start doing veneers. They will give the patient the idea that it's a quick fix. But then that's where things starts to go downhill, and then you are eventually causing more harm to the patient. So the standard of care should not be broken. You should not forget your ethics. At the end of the day, the first thing that we should remember is should not do more harm. Okay, so remember that, and that generally is what answers your question on. Once I talk so much, I mean, and if the patient is kind of little motivated, they understand that I'm not trying to sell them something, and they would mostly agree if they can afford, or if they would want to go ahead and get the treatment done.
Yeah, got
Yeah.
it that way, sir. And also, sir, since finance is also a part of it, so how do you discuss the charges with it regarding the patient?
So charges is something that is kind of touchy when it comes to talking about with the patients, because number one, when you add up everything, it becomes a big number. So you have to be like careful on how you are presenting it to the patient. Generally, I don't talk about the money that much. I focus more on the consent and the ethics part of it, and why the patient needs that. Once they are on that page, I would request my practice manager to send the quotation to the patient. Okay. But if the patient says, okay, give me a ballpark figure, I can always give the patient a couple of options. Okay. Even though I know that there is not much of a difference between those two options, but I always give options to the patient. So, like, I mean, I can tell the patient that I start at X, I have another option at Y, and I have another option at Z. You can choose whatever you want to. So, but generally, the prices, I would give a rough range that this is a ballpark figure, and I would let my practice manager make a PDF or something and send it to the patient for them to, look at it. And then if they have any questions, I discuss with them on the next session. So that way I keep myself out of the money bit most of the time.
Got it, sir.
Yeah.
So, and also another major point is, how do you address concerns such as tooth discoloration or staining in smile makeover?
So generally, when it comes to discoloration and what do you staining, right? So I
Yes.
mean, one, of course, the first thing that all my patients have to understand is importance of oral hygiene. All right. So we do a proper prophylaxis for the patients. Any patient that is wanting to get the veneers done waits for a week for me to evaluate the gingival health. If the gingival health is not healthy, before I start the treatment, I don't do the treatment. Okay, so I will make sure that the tissue is absolutely healthy. If I would, sorry, why the whiteboard opened? Okay, all right. So like, okay, I'll come to those pictures later, but let's talk about step by step. All right. So if I look at this slide, all right, the first thing is, of course, the tissue has to be absolutely healthy. All right. So that's day of the bonding. That's 2 months after bonding. And when I started this patient, the tissue was almost this healthy. Okay. So what the first thing is always to remember that the tissue is healthy before you venture into anything in dentistry. If your tissue is not healthy, you start doing a crown, you do a filling, you do a veneer, you do a full mouth rehabilitation, everything is eventually going to fail. All right. So that's the first thing. Second thing is, when it comes to a discolored tooth, I would, if it is an endo-treated tooth and it is discolored, I would always whiten that tooth first by internal whitening. I mean, I'm not talking about the technique of internal bleaching here. Everybody knows about it, I'm pretty sure. I use endo bleach from Ultradent, Opalescence endo bleach. I do the whitening. I'll try to make sure that one particular tooth, if it is dark, I make it equal to the other teeth. If there are stains, they would probably be removed with your prophylaxis. If it's an old crown, then I would probably change it and try to make sure that it matches the other teeth. If it is like a really bad tooth on one central incisor, then I would probably, I know it would sound more aggressive, but then because that tooth is so dark, I would have to do a zirconia crown on it. Then I would have to do a zirconia crown on the other central as well. Okay, so it becomes a little bit more aggressive, but if there is no other way for me to whiten that particular tooth, I would have to go with the same material at least on the two central incisors, because I cannot afford to have any asymmetry around my central incisors. Those are the two main important teeth. Between the central and the lateral, little bit hardly noticeable. Lateral to the canine, hardly noticeable. So I don't pay that much of, but my both centrals have to look exactly the same at the end of the treatment. So I would try my best to whiten the tooth. If it doesn't get whitened, then we change the material.
Okay, got it, sir.
Yeah,
So it works that way.
yeah,
Sir,
it
and
works.
also, since we are running, yeah, it works that way. We got it, sir. And sir, also, since we are running the digital era, so what role does the digital smile designing software play in your practice?
Now, this is a very good question to be asked in this day and age, wherein everybody's kind of, pushed into that. If you don't have a
Into
scanner,
digital.
you cannot do good work. Or if you don't have a scanner, you cannot do smile designing. All that is absolute bullshit. Okay. So it is something that is important. It is important
Mhm.
for you to know what is going on in the market, but it doesn't matter if you even don't have it. All the cases that I've shown you, they're all done analog way. Okay. None of them has used, of course, there are some cases I've used a scanner to do my final scan, but the
Mhm.
smile designing, generally, I don't use any digital software for two, three reasons. Number one, you are outsourcing it. So somebody is going to charge you for that. Number one. Number two, it doesn't come cheap. So most of the patients would not pay you for that. So you want to eventually pay out of your own pocket. Number three, sometimes we overpromise. So when we do a digital smile design, I can make any smile look absolutely beautiful on Photoshop. Okay, I can do Photoshop. I can change the shape of the face. I can change the shape of the teeth. I can broaden the arch as much as I want to do. I can narrow the arch as much as I want to do. But sometimes clinically, it's not translatable. So what you
That's
should,
not the reality.
yeah, so when the patient would think that, okay, now this looks really nice, you have convinced the patient by your Photoshop skills. But when it comes to your clinical skills, you will not be able to provide it because there are things that you cannot do. You cannot pull a tooth that is inside completely out by doing a crown or a veneer, or a tooth that is really out. You cannot bring it, even if you bring it in, the gingiva would not be in the right place, right? So you tell the patient would remember that photo. You do the treatment, and at the end of the day, it doesn't look like that, and then you are in a problem because the patient would say that I don't like it. So what I personally prefer doing is always that analog way, the direct mock-up technique that works really, really well. I know what I'm doing in the patient's mouth. I know how much bulk I'm increasing. I know how much length I'm increasing. I can show the patient almost the final result then and there. So I kind of still, I don't do digital smile designing that much. I mean, it sounds like a very good concept. It sounds
Mhm.
very fancy, but a lot of times it is not clinically translatable. And that's something that bothers me more than,
Definitely.
yeah. So that's the reason I
It
don't
will
use.
definitely not give us the exact result, right, sir?
Yeah,
Yeah, and also the patient expectation as well.
yeah,
And
you might,
running behind the Mm.
yeah, you might increase the patient expectation quite a bit by doing that.
Just running behind that word, sir. So how do you manage patient expectation regarding the outcome of the smile design?
So that's what I told you when we talk about it. My patients' expectations are set from day one. Okay, so I don't give any
Mhm.
false guarantees. I don't give any false warrant. I lose a lot of patients. Okay, so because there are people in the market, we all know. Of course, everybody has to earn their bread and butter. There is a lot of competition in dentistry. We all know that. But the whole point is, I don't give guarantees, warranties to the patients. All right, that this is 10-year guarantee on the veneer. Imagine I give you an iPhone today and I tell you there is 10-year warranty on it. Would you
Mhm.
take care of it? No, right? You would not take
No,
care of it. You'll be like, I can break it any day. I'll go to Apple
I'll
Store,
get a
get
warranty.
one. I don't I don't care, right? But we all know that how difficult it is to remove an old veneer, or if something breaks down, how much damage it does to the tooth when we have to actually remove it. Okay. And plus the headache of doing it again when the patient is
Definitely.
not taken care of. So my patient expectations are set from day one. What I like to always tell the patient is not that you are not just treating your teeth. It's a full
Mhm.
lifestyle change that we are going to look into. So your
Mhm.
diet would change, your function would change. Of course, your lips will have to adapt on day one. So those Instagram reels where you see that patients are crying suddenly on the day of cementation has never happened with me. Okay, because I mean, one, my provisionals are very nice. So the patients don't see a drastic change between the provisional and the finals. And number two, it's not an easy experience to be on that dental chair. All right.
Mhm.
So when I have to do my bonding, the patient is fully numb. 2 hours I am working in the patient's mouth. I'm struggling. The patient is struggling. So it's not a very happy experience on day one most of the times. It's always after a week when the patient comes back to you, they feel good about it. And that's why the reason I don't take my final pictures within 1 week of cementation. All my final pictures are taken 1 week after cementation. I don't do it on the day of cementation. So it's a lifestyle change. The diet will have to be modified. My patients, whoever I treat, generally live on soft diet. And soft diet, I mean, is smoothies and mashed stuff during the provisional phase. Okay, so none of my patients generally break their provisionals because they take really good care of their provisionals. All right. And the thing is that you have to set the expectation straight. You have to tell the patient that it is not a permanent thing. Lifespan is 10 to 15 years. If you take good care of it, you might still have it for some more time. In
Mhm.
between, you will have chips, you might have cracks. We can always repair it. And then, of course, if a patient, like I did a patient recently who I did 10 veneers on, somebody
Mhm.
banged his head on that patient's mouth, one of the veneer broke. Okay, so then I did change it for free. I mean, I didn't charge the patient for it,
Transportation.
but I didn't tell the patient that you have a 5-year guarantee on it. Okay, because I mean, if I tell that, nobody would be paying attention or keeping them clean or careful of the food that they eat. So that's how
Mhm.
I set the expectations of my patients when it comes to rehabs.
Got it, sir.
Yeah.
And also, we'd be interested to know about the selection of crown and veneer materials used in cosmetic dentistry and their suitability for various procedures.
So material science is important. It's always a changing science when it comes to materials. All right. So generally, all my veneers are lithium disilicate. All right, which are the glass ceramics. I have not done a case with feldspathic ceramics. Two reasons for that. One, of course, none of my patients would are ready to pay that extra charge for feldspathic. Feldspathic is more aesthetic ceramic, but the lab charges of that is huge compared to Emax. Even the Emax that I pay is huge to the lab because I use a very good lab. But at the end of the day, feldspathic is really very expensive, and I don't see a huge difference when it comes to doing it feldspathic or Emax. Okay, so I generally choose lithium disilicates for my veneers. Now I've started using more of lithium disilicate for my posteriors as well, because when you
Mhm.
read literature, the bonding Emax gets, I mean, lithium disilicates get bonded to the tooth because it's a glass ceramic, whereas zirconia bonding is still not that achievable, even though with the APC concept, APC is air abrasion, phosphate monomer, and a resin cement. Okay, that's the APC concept of zirconia bonding. So, but that still is not translated into as strong a bond as your Emax can be bonded. Emax is more aesthetic. So generally my veneer material is always lithium disilicate, which I do the proper bonding protocol to bond it to the tooth. I don't do zirconia veneers, even though some companies do market it. There are newer zirconias in the market. So when it comes to zirconia science, there are the original zirconia was a 5Y zirconia. Okay, that is the 5 Yttria stabilized zirconia, right? That was the 5Y one. That was the first zirconia that was made. Sorry, it was a 3Y. My bad. The 3Y was the one that was the initial one, and then later 5Y came, which is the more aesthetic version of your zirconia. So nowadays you have these monolithic zirconia blocks that are automatically graded between 5Y to 3Y. 5Y on the incisal part, 3Y on your cervical part. So you have the beauty on the incisal part, strength on the cervical.
Interesting.
Yeah, but then still we want strength on the incisal part as well, right? It's not that we don't want strength there. And because it doesn't get bonded well, I generally don't use. So basically for posteriors, I use monolithic zirconia. For my anteriors, I use mainly lithium disilicate, again monolithic. I've stopped complete layering, so no more layering happens in my zirconias because there's a lot of chipping that happens in that layered zirconia. Layered, I mean, you have the core of the zirconia, and on top they layer with feldspathic ceramic. That was people used to do it for aesthetics. But then I see that there is a lot of chipping that happens in that. So now my choice at current stage is generally Emax or zirconia on my posteriors and Emax mainly on my anteriors.
I did it.
Yeah.
Got it, sir. And also, so on the tougher side, what are the potential risks and complications associated with smile design procedures, and how do you mitigate them?
Can you please repeat the question? I'm sorry.
Yes, sir. So, what are the potential risks and complications associated with smile design procedures, and how do you mitigate them? Basically, the risks and complications that we are facing after a smile design procedure,
So,
possible complications.
yeah. So the first complication is, of course, sensitivity, right? We all know that when we touch teeth, we
Yeah.
end up with sensitivity. Second is black triangles. So a lot of times we do cases, we don't pay attention to the gingival position of the contact, and we end up in black triangles where we don't want them. Third is tissue health. So if you don't take care of your margin adaptation, you send it to a cheap lab, you have not taken care of your emergence profile of your veneers, or they are not well adapted. You have left cement while you are cementing. Interdentally, you have not cleaned it good enough. Then gingival inflammation is a big problem. Food impaction, if you have not reduced good enough in the interdental areas, you will have veneers that don't have a proper adaptation in that area, and you will end up with a lot of food impaction in there. Then, of course, recession. If you have a thin gingival biotype, and if you have kind of gone very close to the biological width, or your veneer is not well adapted, your gingiva would just run away from there, especially in thin gingival biotype. So you have to be extra careful in patients with thin gingival biotype. If you are having a thick gingival biotype, it's mainly inflammation that happens. If it is thin gingival biotype, it's mainly recession that happens. So if you are treating a case with thin gingival biotype, be extra careful with your margin adaptation of your veneers. And then, of course, you have occasional chipping, occasional cracking. I mean, that's always happens. But I mean, sensitivity, gingival issues, black triangles. I mean, these are the main issues that I've faced while doing these cases. Yeah.
Yes, sir. Sir, and also recently there was a news of a patient dying on a dental chair due to anesthesia of a smile designing case. So, how would
Yeah.
you comment on this? This is definitely a silly question, but we would like to know from you.
I mean, I don't think it is silly, okay, because it's important when we start neglecting the patient's health, okay, because again, as I told you, patient's health is our priority, okay, so we are treating a patient and not teeth, okay, we are not treating teeth on typhodon. So patient's health is important. You need to understand that even though you can push yourself, even though the patient can't push themselves, some patients are pushy. I want all the teeth to be cut on the same day. I want to do it one day. I want to do it that way or this way. But if you think, generally it won't happen. Okay. So if you are careful, if you have checked the patient's history properly, patient is not on any medication that contraindicates local anesthesia. Patient is not allergic to local anesthesia, and you are careful with injecting, and you have counted the dose of local anesthesia based on the calculations. So if it is 7 milligram per kg, and you are going to inject, so I think there is an 8 to 10 capsules of anesthesia that you can carefully, like, safely inject in a patient, right? But some patients are old, they are not healthy enough, or they are having some respiratory issues, you don't take care of it. So I think it's very important. It's not a silly question. I think patient's health, assessing the patient's health, patient's allergies, patient's overall compatibility with dental treatment, history of patient's old dental treatment. Have they fainted before? Do they have dental anxiety? Do they have issues with dental treatment? Assessing those things are very, very, very important. And I think that is what differentiates you between you being a healthcare professional and you being a quack. So if you don't take care of your patient's health, then that becomes
It
an
turn
issue.
out to be
Shouldn't
fatal.
shouldn't happen. I mean, it can happen with anybody. It might not be dental related. Anybody can get a heart attack at any point of time. Okay, so it's not that something that cannot happen to anybody, but it shouldn't be happening because of your fault. Okay, and I mean, nobody knows when somebody's going to know, you know. Uh,
Yes, sir.
yeah, so being careful, it's not harmful. That's the whole idea.
Yeah,
Yep,
correct, sir.
yep.
Sir, and also, how do you approach cases where patients have existing dental restorations or previous cosmetic work?
All right, so let's see this case quickly. We get an idea. Okay, where is this one? Sorry. Where can I take this? Just give me 1 second and I will show you. Okay, let's see this case. You can see the screen, right?
Yes, sir. Yes, sir.
Okay.
Perfect.
Okay, so this guy, I mean, he came to me. Of course, he got somebody did an implant for him in tooth number 9, which is upper left one. He had these big spaces. All right, so this is a good case to learn a lot of things when it comes to doing rehabs. Okay, so I mean, tooth number 9 was an implant that was placed by somebody. The smile was completely, not really looking great. There was a big diastema between the upper teeth, and the tissue was quite thick, and there was a loss of papilla when we started this case, right? So that's how it kind of looked at the beginning. All right. I did this mock-up for the patient just to understand how the final smile could look like. Okay. So this is not a direct mock-up. This is an indirect mock-up. So I did the direct mock-up. I asked the lab to do the smile designing for me based on my calculations. They did this and sent it to me. I showed it to the patient. Patient said, yeah, this looks fine. Again, this looks very easy to do, but I know that closing those diastemas is going to be quite challenging. My generally armamentarium requires only 4 of these burrs. I use not more than that. So those were the preparations that I did. So because I told you again, as we discussed, I did a zirconia crown on tooth number 8 as well. Even though this was slightly more aggressive than doing a veneer, but because my tooth number 9 crown would come in zirconia, I wanted my tooth number 8 crown to look exactly the same. Okay, that is one thing to notice here. Number 2, my tissue health is absolutely great. Even after putting the cord in, there is no bleeding anywhere except that little bit on the canine on the left side, but generally the tissue looks very, very, very healthy. So a proper retraction. Number 3, whenever there is a diastema, okay, and you would want to close that with a veneer, make sure that you tuck in the margin subgingival in this area. Okay, so even here I push the margin subgingival, even here I pushed it subgingival, even though most of other parts are equigingival. But just because I wanted my restoration to push the papilla in, I have to go subgingival in this area. All my other margins are mostly equigingival or supragingival, but here I had a big gap and I needed to make sure that my papilla fills in. All right, so that's the thing. That's generally the impression. Those were the provisionals. That were the final grounds. Again, my Emax, and this is the health of the tissue on the day of cementation. It looks absolutely healthy. That's the final kind of a thing that we kind of achieved. Of course, we did the lowers as well later. He wanted white. We did white. Okay, you see a little bit blanching here. It's a screw retained implant crown. Okay, this blanching would eventually go away. The tissue would become fine. Okay, that's the texture. That's where we kind of ended from where we started, making sure that there is no black triangles because I put my margins in the correct place. And once you have your margins in the correct place, I mean, your tissue is eventually going to fill in the thing. So, I mean, we have to make sure how we kind of approach a case, because every case is not like, you do the tooth preparation and the lab does the ceramic work and you bond it. So if it was that simple, then, I mean, I'm not saying everybody cannot do it, but it just takes a little bit of knowledge to kind of make sure that you don't end up with frequent complications that can happen. Okay, so that's the whole idea of this particular case.
God, it's a beautiful smile, sir, by the
Yeah,
way.
thank you.
All right, sir. We definitely appreciate your years of practice and expertise, sir. So we would just like to know, how do you ensure long-term stability and durability of the results achieved through smile designing?
As I told you, my patients' expectations are already set in. They know what to do, what not to do, what to eat, what not to eat. Still, issues happen. Most of my patients, I gave a soft night guard. I mean, it's just to protect the restoration on bad days.
A splint, right, sir?
Yeah,
Okay,
very
a
soft,
splint.
soft 1 millimeter splint. It's not for grinding. It's not for TMD. It's not for nothing.
Okay.
It's just to protect them while the patient is sleeping. So and plus again, if a debonding happens at night, patient doesn't aspirate it. So a soft night guard is generally what I prefer giving it to the patient. Some of them would pay for it, some of them won't. If they pay for it, good. If they don't, I pay, I include the lab bill in the total cost and I still make it. So a soft night guard is generally a thing that I give them. I generally give them a water pick. So water pick is something that I would like to give to my patients. So that is really nice. Something like water pick or a water jet from Oral-B or whatever. But it's really helpful. And plus, I made sure that the gingival health is absolutely fine. So it's okay.
Noted, sir. So, considering ortho treatments, what role does it play in your smile design cases, if any?
It does play a big role. Eventually, as I told you, very careful in case selection. If I feel there is crowding, of course, my wife is an orthodontist, so I would refer cases to her. A lot of times, as an orthodontist, they see a lot of things that as a prosthodontist we don't see, or a restorative dentist we don't see. Okay, so there are a lot of things that an orthodontist's eye catches which we would never look at. Okay, sometimes I have done a case and I'm very happy. I come home, and then I get some criticism for the deep bite or overjet, and I didn't pay attention to that. But again, a case which has got mild crowding or cases wherein I feel that orthodontics would help me distribute that, like there is a big space between the central incisors, and I know that I would not be able to close it with crowns or veneers. Or if I do it, those two will start looking very bulky. Then I would send them to the orthodontist. They would, distribute the space between the four teeth, and then I would do four veneers rather than doing two. So I would get four equally proportionate teeth rather than two really big looking teeth. So that's where ortho comes into play. Patients like severe erosion. So I'm treating a case now. Patient has severe erosion because of GERD. The lower teeth have really gone in and touching. There is no space for ceramic. So I send to the orthodontist. They will correct the overjet, overbite, and then send the case to me for being able to do a palatal ceramic veneer or a crown or whatever. We eventually decide. So ortho does play a lot of role. We do a lot of ortho-prosto cases together. But it's just that, sometimes the patients don't come back. Sometimes, they don't agree for ortho. But I would never treat a mild crowding case with veneers. I would not be able to sleep well. So it's something that if it's a young patient for minimal crowding, it's always ortho.
Always ortho.
Yeah.
Noted, sir. Understanding the importance of comprehensive treatment planning. So, how do you collaborate with other dental specialties, such as periodontics, in simple or complex smile design cases?
So perio, again, as I told you, perio is important because I want my tissue to be absolutely healthy. So if I need if I need to do gingivectomy, if I need to do gingivoplasty or something, sometimes I do it on my own. Sometimes I refer to the periodontist. Whenever you do a perio procedure, make sure you wait for at least 2 to 3 months before you do your restorative work. So that's very important. For crown lengthening and all, I generally refer to the periodontist. So periodontist is important when it comes to getting my patient ready for the restorative work. If I am not able to manage that case by simple scaling or whatever it is, and if I feel the need that the patient needs some form of help to be able to achieve good periodontal health, then I would refer to the periodontist.
So
Yeah.
that's also right.
Yep.
So, what post-operative care instructions do you provide to patients undergoing smile design procedure?
We have already covered this question, I think, couple of
Yeah,
yeah.
a couple of other ideas, maybe the complications, right, sir? All right.
Yeah.
So, can you shed some light about the emerging trends or technologies in cosmetic dentistries that you find promising for smile designing?
Of course, digital smile designing is there. There are a lot of
Mm-hmm.
new things that keep coming up. Now there is something like a face scanner. So you scan the face, you do the CBCT, you do a 3D scan. They will all incorporate together and do stuff. Always new materials, new cements that keep coming up. But to be very honest, if you know your basics well, you can adapt to new technologies. But if you don't know your basics well, these technologies will not help you a lot. Okay, so if you don't know how to make a good impression, it will be hardly possible that you'll be able to do a good scan. You get the point, right? If you don't know how to do a proper retraction, whether you do a scan or an impression, or even if somebody gives you a magic wand, you will not be able to capture those margins well, right?
Mm-hmm.
So it's nothing is still 100% like, and good that it is like that, because otherwise we will not exist, right? So good that it still needs some amount of patience and work to do good job. But I mean, there are newer ceramics coming in. There are, resin ceramics coming up these days. There is then zirconia modified lithium disilicates coming in the market. So there is every 3D printing is coming in the market. Now even 3D printed ceramics are coming in the market. So again, there are so many things that keep evolving. But again, how much you are ready or how much your patients are ready for it is a question that we all have to always answer every day, right? Is my patient ready to pay 10,000 dirhams extra for something really fancy? No. If no, then I will have to go back to my basics and do it the basic way, right?
Yeah.
It's
Yes,
okay
sir.
to, always have an idea of newer stuff. But again, I always like to tell everybody to focus on their basics first.
So something similar. So we are also interested to know how do you stay updated regarding the advancements and the best practices in the fields of smile designing?
So one, of course, I mean, you read and read and read. So I mean,
That's it.
that's important. You have to read systematic reviews mainly. Don't. I mean, you can read a clinical article, you can read a clinical paper, but most of them, I mean, they only make sense once you start reading systematic reviews, all right, or you start reading randomized controlled trials. Because when you look at the category of evidence, systematic reviews and randomized controlled trials are having the highest evidence in terms of clinical application. So it's not like you pick up a technique, you like it, you start using it. I mean, of course, it might work for you, it might be a good technique. But again, the importance is that, I mean, if you are incorporating something in your clinical practice, it has to be evidence-based. It cannot be like a company is coming and telling you, okay, this is my cement, this is the best one, start using it, and you just start using it. It's not, it shouldn't be like that. You should be able to tell what that cement contains, what are the properties of that particular material that you are using. Is there something better in the market? Is it the best that you are using? But even if it is not the best, is it doing the job it is supposed to do? So, I mean, and that's how, I mean, attend some conferences here and there. I mean, yeah, I mean, that's how we all learn.
That's how you.
And plus, I
Correct,
mean,
sir.
you work, right? So you work and you do mistakes and you learn from your own mistakes. So that's the
That's
biggest,
always practice, right, sir?
that's why it's called practice. Yeah, unfortunately.
All right, so we have got a lot of information from you today, sir. So now it's your turn, guys. If you guys have any queries, you guys can post it in the chat box. So I guess Dr. Bintuja, we have a question, sir. How can we design using Keynote? That's a
So,
question.
I mean, Keynote generally again was taught by Coachman when they started doing their smile designing thing. Okay. Again, I generally don't use Keynotes. If I really have to do a digital smile design, I would rather, do it through what do you call my mockups and Photoshop if I really have to use, something. So that's generally what I like to, use. And again, I mean, I can show you a couple of other cases if you have 5-10 minutes time. Let's look at a couple of other cases as well. So, no, not this. This is all for the other. There's so much stuff happening in my computer every day. I don't
Uh,
even know where it
it's
goes.
filled, right, sir, with cases.
No,
We
no,
can
not
see
yet.
them.
Some other presentations. Okay, I think I closed that window by mistake. Let me just open a couple of other cases so you can get an idea of what. Let's look at this case, and we have 5 minutes. We can quickly have a look at this case as well. So this patient, of course, came to me with old veneers. Let me go to the top quickly. Yeah. So patient has, I mean, old veneers. She wanted to, I mean, change them. Nothing really bad with them. The proportions were kind of also okay, but they were very fake. There was a lot of gingival issues, bad breath that she had. Some of them were chipped. So there was a temporary bridge on the right side. I mean, so I removed the veneers. Of course, I don't have the hard tissue laser, so I cut them and I removed them. A lot of deposits under them. This is how I just modified the prep a little bit, made the tissue healthy, did my normal retraction with the same process. Digital scan for this patient. So that's, I mean, the provisional. Sorry, that's a provisional that I gave to the patient. Again, making sure that my tissue remains very healthy during the provisional phase. That's on the day of cementation. That's a fit check. So, I was checking the fit, took a photo there. These were the lowers. I mean, again, all of them Emax. That's how it looks 1 week post cementation. I mean, the tissue is absolutely beautiful and healthy, and good integration. Nothing really changed much. Just the proportions I changed a little bit, and plus overall how they look, and I made them a little bit more natural shade than the extreme white that she had. So that was regarding this patient as well. Um, just to end, I mean, before we end, I will answer a couple of questions that where I am generally present, guys. So if you really want to kind of, get in touch with me, if you have any questions, if you have anything, you can always ask me here. And yep, that's where I am mostly available. Any other questions for today?
So yes, it's actually flooding. Can we pick up one more, sir?
Yeah, please pick one or two more. Yeah.
Yes, sir. This is from Dr. Rasuna. So, have you encountered any case with post-operative sensitivity due to gingival recession and patient correlated both together, and any ways to deal with desensitization agents?
I have cases which I ended up with sensitization activity, except I remember a patient who ended up with a very high sensitivity in one of the 20 teeth that I treated. Eventually, we had to do a root canal for that tooth. I mean, there was no other option. I tried everything. I tried, all the desensitization agents. We tried from Shofu, I tried from Tokiyama, I tried from Gluma. Nothing was working on her. And there was something that happened. And even the day I was preparing that tooth was not getting numb at all. So there was some issue with that tooth. Probably there was a crack in that tooth or something. But I think that was the only case I ended up with like really severe sensitivity. But if you try to, do your bonding properly, if you have limited your preparation into enamel, mostly enamel, I mean, you can have preparation in dentine, nothing wrong with it, but try to be in enamel and do proper bonding. And if you have corrected your occlusion properly, there is very little chances that the patient would have sensitivity. But again, I'm not saying it cannot happen. I mean, we all have those patients in which you end up with a lot of sensitivity. So yeah, I mean, so
Yes.
that's what I see. Another question: how long would you wait to final cementation? After crown lengthening, I would wait for 3 months before I even start the preparation. So ideally, I would wait 3 months. I mean, but in most of the cases, we cannot. So I will at least wait for a month if I'm doing anything with the soft tissue. Yeah.
Okay, another question from Dr. Monica, sir. In case of severe erosion, what is preferred, veneers or crowns, or which material should be used?
I mean, if it is severe erosion, I would do a crown mostly. I mean, because it would be only on the parietal side, it would still have chipped. So those generally go for crowns. I mean, severe erosions mostly go for crowns. And I can choose anything. I mean, I can choose Emax, I can choose zirconia. I mean, it's not like something hard and fast to choose the material there. But because the enamel would be very less, bonding would be anyways compromised. So if strength is my primary criteria, patient is a heavy bruxer, I would go for zirconia monolithic. They are still very aesthetic. If patient is not a bruxer, I see the masseters are not really bulked up. I know that the patient is not grinding enough. I can go with Emax because I can achieve at least some form of bonding with glass ceramics.
Noted, sir. So let's pick up the last question for the day. Just for the day, else you can always ping sir or us. We'll connect with sir. So it's from Dr. Alia. How to avoid dark triangles during smile designing?
So for avoiding black triangles, if you want to remember something, is whenever you do your veneers, one, avoid square-shaped teeth or avoid triangular design of the teeth. So try to have a little rectangular tooth or a slightly oval tooth with a broader contact, and make sure that the distance between the crest of your alveolar ridge and the top of your contact is not more than 5 millimeters. So studies have shown that if it is 5 millimeters or less, you would never have a black triangle. But if it goes from 5 to 6, you have 30% chances of having a black triangle. So I mean that evaluate. That's why in normal teeth the contacts are generally not that broad. But when we are doing smile designing, you would see that most of my cases have a slightly broader contact. At least I'm close within that 5 millimeter range, and I don't end up with a black triangle. And on the day of bonding, you might feel that you have a black triangle, but always don't worry about it. Maybe in a week's time, if you have made sure of the values that I've told you, the tissue would fill in. So if there was a diastema initially, and if you have put the margin subgingival, 1 week later it would fill. Yeah.
Over time, it would fill it. Is that so?
Yeah.
So thank you, sir, for spending so much time with online dentistry and giving us a lot of information. Thank you all. Thank you, sir.
Thank you so much. I hope everybody had some information to take.
Definitely, sir. Our
Yeah.
chat box is actually flooding. This will be noted and given to sir, and it will be answered by sir later. So thank you all. Good
Have a
night.
good day.
Take care.